This is Rozicap ASP 2075, a pharmaceutical capsule frequently utilized by cardiologists to manage high-risk cardiovascular patients. Inside this single oral dosage are two exact pharmacological agents, 20 milligrams of rosuvastatin and 75 milligrams of aspirin. Patients typically utilize this combination to lower cholesterol, manage blood viscosity, and treat the symptoms of angina or arterial blockages. In the context of clinical pharmacology, these mechanisms are defined as an HMG-CoA reductase inhibitor operating alongside a platelet aggregation inhibitor. When a patient presents with recurrent heart blockages, deploying both of these specific mechanisms simultaneously is a clinical necessity. Advanced ischemic heart disease exhibits two distinct modes of failure: a chronic structural deterioration of the vessel walls and an acute chemical clotting event. Managing this pathology requires a dual-axis intervention that simultaneously suppresses lipid synthesis in the liver while inhibiting platelet aggregation in the blood. To understand the synergistic effect of this therapy, we will deconstruct the exact pharmacodynamics of both the 20 mg statin and the 75 mg aspirin doses. Evaluating the true efficacy of this fixed-dose combination requires looking past the gross anatomy of the heart and zooming down to the endothelial and biochemical levels. The first physiological target of this capsule is the liver, the primary command center for systemic cholesterol regulation. Look at this diagram of a hepatic cell. Deep within the endoplasmic reticulum, we can trace a continuous biochemical flowchart known as the mevalonate pathway. The critical rate-limiting enzyme governing this entire cholesterol synthesis pathway is HMG-CoA reductase. Rosuvastatin operates as a highly effective competitive inhibitor, physically binding to the HMG-CoA reductase enzyme and blocking its function. The immediate intracellular consequence is a sharp decrease in the liver's internal cholesterol stores. To survive this depletion, the hepatic cells upregulate LDL receptors on their surface, rapidly scavenging circulating LDL cholesterol directly out of the bloodstream. The 20 mg dosage of rosuvastatin is specifically categorized as high-intensity statin therapy, a deliberate escalation from a standard maintenance dose. In secondary prevention, this 20 mg dose stabilizes the physical architecture of the vessel wall, a clinical goal that persists regardless of the baseline numbers on a lipid panel. By continuously suppressing hepatic lipid synthesis, rosuvastatin halts chronic plaque growth and structurally stabilizes the fibrous cap of existing atherosclerotic plaques, mitigating the risk of a rupture. To map that risk, we shift the anatomical focus from the liver to a coronary artery severely restricted by atherosclerosis. The physical pain manifestation of this restricted myocardial blood flow is clinically diagnosed as angina pectoris. This cross-section details the microscopic anatomy of an atherosclerotic plaque. Note the structural division between the protective outer fibrous cap and the highly dangerous necrotic core underneath. The acute failure mode initiates when a microscopic fissure or rupture forms in a weakened, unstable section of that fibrous cap. Instantly, the highly thrombogenic tissue factor, sealed inside the necrotic core, is exposed to the flowing blood. This exposure overrides normal hemostasis, triggering an immediate and uncontrolled coagulation cascade. This microscopic enzymatic event scales up rapidly, resulting in the total occlusion of the artery, the mechanism behind a heart attack. While statins work longitudinally over years to prevent the rupture from occurring, the patient requires a localized chemical safeguard the exact second the physical architecture fails. That safeguard targets the immediate cellular first responders arriving at the site of the plaque rupture, circulating blood platelets. As a platelet drifts past the fissure, it detects the specific chemical signals emitted by the exposed tissue factor. The schematic visualizes the arachidonic acid pathway, the internal signaling mechanism inside the platelet responsible for its activation. The central node driving this pathway is the cyclooxygenase 1, or COX-1, enzyme. COX-1 synthesizes thromboxane A2, a potent lipid that forces platelets to aggressively clump together and causes the surrounding blood vessels to constrict. Here, we introduce the second active ingredient of the capsule, acetylsalicylic acid, or aspirin, the blood thinner mentioned in the source material. Aspirin initiates irreversible acetylation. The molecule permanently binds to and disables the COX-1 enzyme node inside the platelet. As a result of this binding, the platelet is chemically blinded. It loses the internal signal required to aggregate, halting the lethal clot formation before it occludes the artery. The dosage of exactly 75 milligrams is significantly lower than the amounts typically used for systemic pain relief. This specific dose accounts for the unique biology of platelets. Because they lack a nucleus, once aspirin disables their COX-1 supply, they cannot synthesize new enzymes to replace them. The 75 milligram threshold is high enough to permanently disable these circulating platelets without depleting the protective prostaglandins that line the patient's stomach. Low-dose aspirin provides a permanent circulating chemical inhibition, ensuring constant protection against fatal clot formation at any site of vascular injury. By viewing the broader cardiovascular system, we integrate the upstream lipid regulation of the liver with the downstream platelet activity in the bloodstream. The fixed-dose combination capsule executes a strict pharmacological synergy. Operating on a timeline of months and years, rosuvastatin dictates the structural integrity of the vessel walls to maintain chronic defense. Operating in seconds during a microscopic plaque crisis, aspirin provides rapid response damage control for acute defense. This split-screen schematic isolates the domains. The left provides an upstream metabolic correction, the right acts as a downstream emergency brake. This compounding mechanism requires a cardiologist's prescription. Physicians must carefully balance complex lipid targets against the severe bleeding risks of irreversible platelet inhibition. This pill integrates these two distinct biochemical interventions into a single clinical protocol. A formulation like Rozicap ASP 2075 demonstrates the precise biochemical engineering required to preempt and neutralize the two most lethal failure modes of the human cardiovascular system.